Good evening, dear friends of modern medical profession. Indian Medical Association, the committed organization for the profession, the modern medicine, and its frontline warriors like you people. See, we form the cornerstone of public health in India. And let us empower ourselves with essentials of every day in modern medicine. Dear friends, medicine. Those who can hear, please disconnect your audio from your device and then restart. I hope you can hear, everyone can hear our program. If you have any problem, you just send me messages, okay? So friends, Indian Medical Association has its oldest academic wing, evergreen academic wing, the College of General Practitioners. Indian Medical Association Kerala State is proud to have its best academic wing as IMA College of General Practitioners, with myself as currently designated Director of Studies and the Secretary, Dr. Biju Nelson. And we are just representative of this great organization. We are just working in front of you for the organization, powered totally from Indian Medical Association, the world's largest organization, professional organization for doctors. Friends, with this introduction, let us start the program. And as you all know, this is a weekly webinar series on every Thursday. You might have seen that we are blessed with abundant array of, the not only just experts, they are the giants of modern medicine, rather pillars of modern medicine, coming again to our classroom to refresh ourselves with the wisdom of their decades of their wisdom. And they are coming to us for empowering us by every means. And our concept is to bringing you the essentials of every day in modern medicine. And let us learn, let us listen to these great faculties. And please note that the Zoom ID, the Zoom passcode, and the link that which you have used today is same for next week and subsequent weeks till November. Okay, with this humble introduction, let me proudly invite our beloved secretary of IMA College of General Practitioners. He's a very good artist too, and he's a very senior member of our profession, Dr. Biju Nelson. Let me heartily welcome Dr. Biju Nelson and the faculty of the day, our beloved Professor Emeritus Dr. Dayananda Babu sir. And before the program starts, let me invite Dr. Biju Nelson to introduce the well-known, it is a very difficult task. It's a well-known, legendary faculty, Dr. Dayananda Babu sir. Over to you, Dr. Biju Nelson.
Good evening, Dr. Prashant, Director of Studies, our chief guest of the day, Professor Dayananda Babu, and all ladies and gentlemen. It is my pleasure to introduce our distinguished speaker, Dr. Dayananda Babu, an eminent general surgeon and endocrine surgeon and professor of emeritus at Sri Gokulam Medical College, Trivandrum. A highly respectful surgeon, teacher, and academician, Dr. Dayananda Babu has given outstanding contribution to surgical practice and medical education. He was the past national president of Indian Association of Endocrine Surgeons, widely admired for his expertise, dedication, commitment for to training surgeons across India. We are privileged to have him with us today to share his knowledge and experience. With this, ladies and gentlemen, please join with us to hear the expert opinion from Professor Dayananda Babu. Thank you.
Thank you, Dr. Biju Nelson. Friends, now let us hear the wisdom on acute abdomen. Sir, Dr. Dayananda Babu sir is a biggest dictionary or encyclopedia for any topic in general surgery, particularly general surgery, and he's one of the widely respected teacher, evergreen teacher of general surgery. And he has always remained a very good friend of Indian Medical Association to wherever he was there. And so let's join our hands to offer a hearty welcome along with Dr. Biju Nelson. Hearty welcome, sir. Over to you, sir.
Prashant,
Yes, sir.
am I audible?
Yes, very much, sir. And your slide is also visible.
Visible. Okay, it is in full screen.
Yes, sir.
So let me at the very outset thank the organizers, especially my dear friends Prashant and the secretary Biju Nelson. Uh, I think it's a good opportunity for me to interact with the members of the Indian Medical Association who are listening to this talk. At the outset, let me thank Prashant and Biju Nelson for the very nice words spoken about me. Now, as you know, I am going to talk on acute abdomen. 1 minute. The term acute abdomen is widely used to denote the rapid onset of abdominal pain, which is severe enough to warrant the patient's admission to the hospital. Acute abdomen designates symptoms and signs of intra-abdominal disease, usually treated best by surgical operation. 5 to 10% of all emergency department visits are for acute abdominal pain, and only 1/5 of these are admitted. And 4/10 are discharged without any definite diagnosis of the pain. Some will have life-threatening condition that will require surgical intervention immediately or after resuscitation. Others need a period of active observation and conservative management that may lead to surgery. I want to quote a chapter from the famous novel, The Final Diagnosis, written by Arthur Haley, the fourth chapter. Here, the fourth chapter is a scene of mortality conference where a surgeon has operated for perforation of viscera by a laparotomy, and then there was nothing in the abdomen, and the patient is dying on the third day, and the postmortem revealed a pneumonia. So it was a wrong diagnosis. The pneumonia was presenting us as acute abdomen, and he has operated. So that is well described. The scene is very nicely described by Arthur Haley in Final Diagnosis. So one should remember that sometimes the medical problem, especially the coronary artery disease, can present as epigastric pain. So also the pneumonia. Another condition is called the Valentine appendix. It's also called Valentino syndrome. Again, it's a story of the Rudolph Valentine, an Italian actor who was operated at New York in 1926 for acute appendicitis. And the appendix was found to be normal. And then later on, after 2-3 days, the Valentine died. And the postmortem revealed that he was having a perforated duodenal ulcer. So as a result of perforation, the fluid will track along the right paracolic gutter and will come to the right iliac fossa and may present as a right iliac fossa pain. So these two, so this is called Valentino syndrome or Valentine appendix. And two more stories so I want to tell, which I have encountered, the story of an unmarried girl. While I was taking duty in Kottayam Medical College, one girl came to the casualty with right lower quadrant, the right iliac fossa pain, classical right iliac fossa pain. And then I have examined her. There was no physical finding. And then I have kept her under observation for 24 hours. Next day morning, I found that there is nothing in the abdomen. Therefore, I have discharged her. This girl again came to the casualty after a week, and the duty surgeon operated her by appendicectomy. This girl, the third visit after 9 months, she is coming to the casualty with a mass abdomen, and the parents are attributing this mass as attributing everything to the appendicectomy done 9 months before that. On examination, she was having a full gravid uterus. And then, of course, what happened? We have sent her to the labor room. She delivered. So this shows the importance of asking the LMP, and then doing, one should rule out pregnancy at least by a pregnancy test before doing appendicectomy in females. My professor, CKP Menon in Trivandrum, used to tell us that there is no acute appendicitis in females, showing that you have to rule out many other conditions in females like pelvic inflammatory disease, or maybe ovarian or ectopic pregnancy, so many things. And also, you should make a pelvic examination before planning to do appendicectomy in female. The second story, again, a college student, while I was on duty in LP Medical College, uh, he came with abdominal pain and vomiting. And on examination of the abdomen, there was nothing, no clinical findings. And then I kept her in the observation. In the evening, my unit chief, that time Professor Chaco Valail, came, and he immediately after coming, he just removed his clothes and found that there is an obstructed hernia. So I missed this because this boy was very shy, very timid. I didn't want to disturb him. So the lesson is, whosoever it may be, you have to examine the genitalia in all cases of acute abdominal pain. Otherwise, you may miss these findings of maybe obstructed hernia, especially in old females, maybe obstructed femoral hernia. So examination of the hernial orifices are very important for acute abdomen, or for that matter, any abdominal pain. So inflammation is the most common cause of acute pathology in the abdomen, followed by obstruction, hemorrhage, trauma, ischemia, etc. And the causative factor may be bacteria, virus, fungal, parasites, and maybe other causes also. Now, an analysis of acute abdominal pain by this study showed that the commonest cause is non-specific abdominal pain, which doesn't require any surgery, 34 causes out of 100. And then acute appendicitis, 28, acute cholecystitis, 10, small bowel obstruction, 4, gynecological conditions, 3. So, and then, of course, acute pancreatitis. Nowadays, I find that the acute pancreatitis, the incidence is more, very high, especially with the incidence of the alcoholism being more in our state. The acute pancreatitis is. And then, of course, renal colic, perforated ulcer, malignancy, diverticulitis, this all causes are. But most important cause, I think, is appendicitis. Before that, the non-specific abdominal pain. This picture, I need some time because this is a picture of a building. You know that this is the attic. Attic means this attic is up up to the diaphragm. So this is the boundary of the attic. So the chest, as mentioned before, the pneumonia, cardiac problems, or even tonsillitis can sometimes cause acute abdominal pain. So that is the attic. And then second is, I will say, the upper story. The boundary is from the diaphragm. Where is my cursor? 1 minute. Yeah. The upper story is from the diaphragm to the umbilicus. The upper story, you get so many, especially the foregut, the gastric ulcer, or duodenal ulcer perforation, or the acute pancreatitis, or malignancies in the upper GI tract. All those things may be perforation of stomach. All those things can cause acute abdominal pain. The second limit is from the limit, the umbilical area, the umbilical area to the brim of the pelvis, which is shown as the green color. So that is up to the brim of the pelvis. And here you get the intestinal obstruction, mesenteric adenitis, gastroenteritis, enterocolitis, intersusception, carcinoma of the cecum, diverticulitis, torsion of the mesenteric infarction, leaking aortic aneurysm. All those things are there in the ground floor. So we have reached up to the ground floor, and then we have got the basement. The basement is the pelvis. The pelvic, various organs in the pelvis, maybe the ovarian problems, rupture, ectopic pregnancy, or twisted ovarian, or maybe pelvic inflammatory disease. All those things will come in the basement. So if you remember this picture, and then moreover, then you got the backyard. A backyard is the retroperitoneum. Retroperitoneum, you got the maybe uretary colic, or maybe retroperitoneal hematoma. All those things will come in the backyard. The oil tank is the vessel, fuel tank, I will say, where the vascular problems, especially the hematological problems, the sickle cell anemia, or maybe other vascular problems like enoxazoline purpura, or maybe anticoagulants. Those things can cause pain. That is the fuel or the oil tank area. And then the electrical installation. So the electrical installation, I think I have to mention the tabes, the old tabes, or the herpetic pain. Patient may develop vesicles along the segments. So herpetic pain or tabes dorsalis, all those things, or maybe spinal problems can produce abdominal pain. So this is actually, this picture is the differential diagnosis for an acute abdominal pain. If you can think of this picture, you can remember all the causes for acute abdominal pain. And then coming to the examination, the history is very important. I have stressed the importance of 2-3 things, and I'll be stressing more things in the coming slides. Examination, general, local examination, and the classical inspection, palpation, percussion, auscultation. The star is the site of the pain, then the site of the severity of the pain, time of the pain, the type of the pain, the aggravating factors, the alleviating factors, referred pain, and radiation. So this short form is for you to remember how one should approach the acute abdominal pain. And you should differentiate colicky pain and continuous pain. The colicky pain is the classically seen in intestinal colic, and this is where you get the pain will start, then the pain will reach a peak. This is called a crescendo phase, and from there it will descend, decrescendo phase, and then there will be a normal period, and then again the pain will come. So that is called a colicky pain. So whenever a patient is coming with pain, one should ask whether it is a colicky pain or a continuous pain. Second is biliary colic. A biliary colic is actually a misnomer. It is not a colic. Once the pain will start, it will reach a peak, and then it will remain there for at least 15 to 20 or 25 minutes, and it will slowly come down. So it is a severe type of pain. It will radiate to the back, means the inferior angle of the scapula, below that. So that is the typical radiation of a biliary colic, may or may not be associated with vomiting. Uretary colic, again it is typical colic from the loin to groin type of pain. From the loin, it will go to the groin. Again, typical colic only. And then the pain from intra-abdominal viscera, it is better to know that there are two types of pain. One is a visceral pain. Second is the parietal pain. The visceral pain is due to the inflammation or distension of the viscera. And the visceral pain will be seen in three places. The foregut visceral pain will be seen in epigastrium and the surrounding area. The midgut pain is around the umbilicus, and the hindgut pain in the hypogastrium. So by the location of the pain, you will be able to, so it is better to ask the patient where exactly the foregut is up to the second part of the duodenum. And then the midgut is from the second part of the duodenum to half of the transverse colon. And the hindgut is from the transverse colon to the distal part. So if a patient is having hypogastric pain, one should suspect a pain originating from hindgut. Around the umbilicus, it should be from the second part of the duodenum to the transverse colon. So by the site, you will be able to know the area of the viscera involved. And once the parietal peritoneum is involved, the patient will be able to localize. This is why you are getting a typical migratory pain in acute appendicitis. Initially, it is a visceral pain, and there will be distension of the appendix. So the patient will have pain around the umbilicus. And later on, the parietal peritoneum or the right iliac fossa will be involved. And then the pain will reach the right iliac fossa. So this is called the typical migratory pain. It is not radiation. So visceral pain going to form or forming the parietal pain. And this is again important, the Mittelsmursch. This is called a Mittelsmursch, which is nothing but the mid-cycle rupture of the follicular cyst. So always take history of the LMP. And if the patient is having a mid-menstrual cycle, that is around 14 or 13 to 15 or 16 days pain, one of the causes is rupture of the follicle, the ovarian follicle, and there will be little oozing, especially if the rupture of the follicle is happening on the right side. That will produce right iliac fossa pain. It is not due to appendix. In children, acute inflammation of the upper respiratory tract can present as abdominal pain. Examine the tonsil and the eardrum. It's called the tonsil tummy. The children will swallow those things, and it will go to the abdominal cavity and will produce abdominal pain. This is called tonsil tummy. So that's the importance of examining the upper airway also. Analgesic medication is nowadays considered an integral part of patient resuscitation as it minimizes stress response and facilitates cooperation during physical examination. Now one should examine, look for the vital signs, pulse rate, respiratory rate, temperature, blood pressure, all those things. And one should observe for distension. Visible peristalsis, I think, elaborate, right? I need to elaborate. There are three important types of visible peristalsis. One is the visible gastric peristalsis that we call VGP, and the direction of the visible gastric peristalsis will be from left to right. So if you should observe for at least 10 minutes. If the visible gastric peristalsis is there, there is some obstruction of the duodenum also. And then the second type is this right to left, which is due to the colonic obstruction. If there is a growth in the left side of the colon, then as a result of the colonic obstruction, the visible peristalsis will occur from right to left. And the third type is the most important, which is called the step ladder type of visible peristalsis, which is due to small intestinal obstruction. So if visible peristalsis is there, one should note down and the direction and the type of visible peristalsis. And then maybe ecchymosis. If there is ecchymosis of the flank, it is called the Great Turner sign, which may be due to the acute pancreatitis or some retroperitoneal hemorrhage. Another sign is called Cullen sign. Cullen sign is due to initially classically described for ectopic pregnancy. It's discoloration around the umbilicus. So if there is discoloration around the umbilicus, maybe a ectopic pregnancy rupture or maybe abdominal aortic aneurysm rupture or some hematoma inside the peritoneum. And then look for visible masses. Previous operation scars, very important because one of the commonest causes for small intestinal obstruction is adhesion. So any abdominal scar is there, one should suspect adhesion. And the most important scar for us is the appendicular appendicectomy scar, and that is one of the most important causes for adhesive obstruction. And then the pointing sign. You ask the patient to point. Where is your exact site of pain, which most of the patients will be able to tell if there is a real pain. And then cough test. Make him cough. And if the patient will wince and point to the side, that if there is the peritoneal involvement, he will definitely wince. Bed shaking test. Again, it's a sign for peritonitis, which is called Bappat sign. He will immediately say that there is pain. And percussion, two types of rebound tenderness. We usually use the rebound tenderness by pressing and suddenly releasing. That is called the Blumberg sign. But you can also percuss without much disturbance to the patient, which will not cause much pain. That is percussion rebound. Three groups of abnormalities are there for the acute abdomen. One is the signs of peritonitis, the second signs of masses, and the third is abdominal distension. Now, the four signs of peritonitis are tenderness, guarding, rigidity, rebound tenderness. So, if these four things are there, one should rule out a peritonitis: tenderness, guarding, rigidity, rebound tenderness. And the difference between guarding and rigidity, guarding is reflex contraction of the muscles, whereas the rigidity is involuntary. The patient is not responsible for rigidity. So reflex contraction, whenever you are palpating, that will happen. That is called guarding. Rigidity without palpation also, there is involuntary increase in the resting tone of the abdominal muscle. And then auscultation. Auscultation, one should know where to auscultate. I have seen many doctors auscultating in the left iliac fossa, upper abdomen. No, one should auscultate and just below the umbilicus on the right side. So maybe around right iliac fossa side. And one should auscultate for at least 3 minutes before reaching the conclusion of absent bowel sounds. And then digital rectal examination is important. And along with digital rectal examination in females, you can palpate the cervix if tenderness is there, maybe pelvic inflammatory disease, or maybe if pelvic appendix is there, that also will give tenderness on pelvic examination. And then masses in the pelvis. And look for the blood and mucus in the finger stall of the palpating finger. And then investigations, of course, I'm just giving you the basics only, the hemoglobin, full blood count, which called a shift to the left. If there is leukocytosis and immature forms are there, we call it shift to the left. So if immature forms are there, it is shift to the left and usually seen in acute appendicitis. And peripheral smear examination is important. Maybe you can diagnose the hematological condition, especially the sickle cell. You can identify in peripheral smear, urine analysis for sugar, acetone, because the diabetic ketoacidosis will produce abdominal pain. And then urea, electrolytes, serum amylase, LFT, and then maybe if required, blood grouping, cross-matching. Nowadays, generally, we don't give blood unnecessarily. And then, as mentioned earlier, the urine pregnancy test is very important, and beta HCG also. Serum amylase level 4 times the normal is indicative of acute pancreatitis. It is also elevated in perforated peptic ulcer or ruptured aortic aneurysm, intestinal gangrene, etc. And then X-ray, plain X-ray. Nowadays, the gastro surgeons, they will go by, initially itself, they will go by CT. So I don't want to mention CT because most of you are doing, I think, general practice. And from the general practitioner's point of view, an erect chest X-ray is the most important X-ray for gas under the diaphragm. Not the abdomen, placed abdomen erect. Better is chest X-ray erect posture, not abdomen. And you will notice gas under the diaphragm. If the patient cannot stand, the best view will be given by left lateral decubitus, and then on the right side you can see gas. This is called left lateral decubitus view. And then for intestinal obstruction, usually we take 2 X-rays, plain X-ray, abdomen, supine, and erect. But I will say the most important thing is supine. In supine, you get the intestinal pattern. In the erect posture, you get fluid levels. So fluid levels are not, it will just suggest obstruction. What most important is the supine plain X-ray abdomen, which will show the intestinal pattern. You should know the patterns, the valvulae conniventes of jejunum, the structureless pattern of ileum, and hostrations of the colon. So these are the intestinal patterns which you see in supine abdominal X-ray. And then you may see free blood or fluid in the peritoneal cavity, a distortion of stomach by air bubble, obliteration of psoas shadow, kidney outlines will be visualized, calculi can be seen, calcified wall of aneurysms, and then fractures of ribs, spine, pelvis, etc. can be identified. Contrast radiology, the role of contrast radiology is with the introduction of CT nowadays coming down. But certain situations may need contrast animals, at least for the large bowel obstruction, especially volvulus of sigmoid. And it can differentiate mechanical obstruction from pseudo obstruction. The pseudo obstruction is called Ogilvie syndrome. A dilated colon will be seen without any mechanical cause. And then the water soluble contrast is better used. Contrast solo may be used for rupture of the esophagus, etc. Gastrographin has got its own problems. It is hypertonic, electrolyte imbalance may occur, significant fluid shift can occur, and also the pulmonary edema can occur. Endoscopy is not routine, may be required in some cases. Ultrasound is the basic investigation for any acute abdomen, and we call it it's an extension of the clinical exam. So ultrasound is called the extension of clinical examination, and it is very cheap. And that is I will say, first nowadays, even before going to the plain X-ray, people do ultrasonogram. You can make a diagnosis of cholecystitis, acute appendicitis. If you see a tense tubular structure more than 6 mm, that is suggestive of acute appendicitis. So if an ultrasound gives a picture of tense tubular, tender tense tubular structure more than 6 mm, that is suggestive of acute appendicitis. And then I can also make diagnosis of intra-abdominal abscesses, fluid collection, pseudocyst, ascites, etc. And obstructive jaundice is again, it will show intrahepatic biliary radical dilatation. So the sonological finding is intrahepatic biliary radical dilatation, which is suggestive of obstructive jaundice. And then abdominal masses, aortic aneurysm, all those things can be diagnosed by ultrasound. Excess abdominal gas interferes with the ultrasound. So that is one thing, negative thing about ultrasound, because gas is an enemy for ultrasound. And a detailed sonographic evaluation of abdominal organs are interfered by the gas. Then for appendicitis, it will demonstrate an appendicoline. You know that there are two types of appendicitis. One is called obstructive appendicitis. Second is called the catarrhal appendicitis. The catarrhal appendicitis, even if you don't do anything, nothing will happen. But the obstructive appendicitis is the one which you need immediate operation. As I have mentioned the finding, and then you can also see pericecal inflammatory changes in the ultrasound. So this is the most important. I said the gastrosurgeons straight away go to CT, acute abdomen protocol. The CT is good for diagnosis of acute appendicitis, defines the changes of complicated appendicitis, differentiates periappendiceal inflammation from abscess, and angio-CT is important for pancreatic necrosis, especially in pancreatitis, and detects many other diseases, the site of obstruction in intestinal obstruction, and the area of any perforation other than the duodenal ulcer, maybe a ileal perforation. All those things will be identified by CT scan. And the CT has got 98% sensitivity, 98% specificity. The positive predictive value is again 98%. Negative predictive value again. And overall accuracy of CT is 98%. The blood and other fluids can be identified by CT. Mesenteric venous thrombosis. And arterial occlusion, mesenteric arterial occlusion also will be demonstrated. Diverticulitis and its complications, the pericolic collections, pancreatic edema, fluid collection, hemorrhage, necrosis of the pancreas, abscess, pseudosis, all those things can be identified by a CT scan. So the clinical examination plus plain film may be 50% correct. A CT scanning may be, as mentioned earlier, 95% correct, accurately detects the lesion at least in 57.5%. So clinical examination as such will be maybe 17.5% accuracy is there. That doesn't mean that you don't have to examine the patient clinically. That is why most of the young new generation doctors are going for investigation from the very beginning. But clinical examination is very, very important. Correct clinical diagnosis for the most experienced will be possible in 4 out of 5 cases. There is something called a computer-assisted diagnosis of acute abdomen. Now AI is there, so that will give many. If you feed the results, that will give a diagnosis, which may be sometimes wrong also. And you have got various scoring systems. Most important scoring system is called Alvarado score. Alvarado score, which is for the acute appendicitis. And this is called, for easy remembrance, we call it mantral. Mantral is migratory pain, that is M. A for anorexia, N for nausea, vomiting. And then there are 3 signs: tenderness, T, tenderness, rebound tenderness, and elevated temperature, mantral, and then L for leukocytosis. Again, 2 points are given, and shift to the left, 1 point. So this is the mantral score, otherwise called the Alvarado score. If it is 7 or more, it is strongly predictive of appendicitis. 5 to 6 is equivocal. So I think if this may be good for the general practitioners, mandrel scoring. And then plain film findings. This picture shows a hydropneumothorax, that is after perforation there is fluid collection. You see a perfect horizontal cut, which is that shows that it is not limited to one intestinal lumen, that is suggestive fluid in the peritoneal cavity. Then the hydropneumoperitoneum, again you can see the border. The free air is well defined by the interface. The fluid with the fluid in the peritoneal cavity, showing the arrows there. Acute cholecystitis again shows 2 small stones. The curved arrows are showing the stones there present in the neck of the gallbladder. The wall of the gallbladder towards the fundus is thick. The wall thickness is very important, shown by the straight arrow. And then there is the pericholecystic collection also. This is the pericholecystic collection. So if you have got a sonologist, you can go and see. And then there is something called the acoustic shadowing. Whenever there is a stone, you get a window like this. This is called acoustic shadowing. So acoustic shadowing is suggestive of a stone inside, right? Acute appendicitis showing again radiographically non-opaque. Usually the fecolates or the appendicolates are not radio opaque, but here you can see one stone in the lumen of the usually it will be at the base of the appendix, and then you can see there is an acoustic shadowing window down there. So there is a distended appendix with appendicolate, and if it is not treated, it will perforate, unlike the catarrhal appendicitis. Perforated, unsuspected perforated duodenal ulcer, CT was taken. The CT here shows a small amount of gas which is seen lateral to the duodenum. So CT, the importance of CT here. So the gas shadow outside the duodenum. CT scan of uncomplicated appendicitis, a thick-walled distended retrocecal appendix is shown by the arrow, is seen with the inflammatory changes with surrounding fat. A retrocecal appendiceal abscess is seen here. Sometimes you get a appendicular mass and then it is maybe difficult to differentiate it from carcinomas, cecum. So here we can see an abscess, retrocecal. So say the two words are there, Flackman and abscess. Flackman is the American terminology for mass. This is seen in a patient 3 weeks postpartum, obese women. Inflammatory changes extends throughout the flank musculature into the even the subcutaneous fat. The inflammatory changes are seen here. Even the subcutaneous fat, it is there. So it is suggestive of appendicitis. So initially, if you do upright chest X-ray, if free air is seen, laparoscopy or laparotomy. Nowadays, most of the duodenal perforations are operated by laparoscopy and closure. If there is no free air, we can absorb and do further studies. A possible acute abdomen atypical presentation, thin patient, do ultrasound. Abnormal, you go for laparoscopy or laparotomy. If the ultrasound is normal, observe and further studies. Obese patient do better always, and as I mentioned earlier, gastrosurgeons always they do acute abdomen CT protocol, and abnormal laparoscopy or laparotomy. Normal, observe and further study. Generalized abdominal pain, elevated amylase or lipase, give contrast CT. If the pancreas is abnormal, then you give symptomatic care. If the pancreas is normal, do laparoscopy. So this is the protocol, and the quartet of symptoms of intestinal obstruction one should know: the colicky pain, vomiting, distension, and constipation. These are the 4 symptoms. Most common cause is adhesion, as I have mentioned earlier, followed by hernia. So the commonest cause for intestinal obstruction is by adhesion, followed by hernia. Signs of obstruction, shock, and peritonitis suggest strangulation. The femoral hernia is overlooked in intestinal obstruction. Obstruction of large bowel is due to cancer of the colon or sometimes an ovarian malignancy obstructing the colon. Volvulus, again, is something which one should, if you have seen a volvulus, you will never forget, especially the pneumatic tire appearance of the distended sigmoid. And then, of course, contrast radiology, if may be required sometimes for intestinal obstruction. Perforation of peptic ulcer, there is a surgeon called Zachary Coe. He is very fond of rhymes, and the rhyme given, and now I will picture, if I can, the perforated ulcer plan, like Murder in the Cathedral of T.S. Eliot. It is a 3-act play. The first act is like a thunder, a bolt from the blue when the patient is writhing in agony, and you stand as a witness guessing. This is the stage of chemical peritonitis. So that is the first stage of any peritonitis of perforation, which is called stage of chemical peritonitis. The second stage act is a deception. It is called the act of illusion. a stage of illusion, a short-lived comfort for the patient and for the surgeon, and elusive satisfaction. So it is called stage of illusion, the second stage. And the third act is a sad remorse. The disease takes a fatal course unless your courage and skill can turn the corner around. But most important is the postmortem, which reveals the actors devoid of any makeup and brings out the true character, which frequently is a diagnostic disgrace for the doctor. Acute abdomen with shock, four important causes: ruptured abdominal aortic aneurysm, acute hemorrhagic pancreatitis, acute ischemic bowel, especially if the patient is fibrillating. Or a thrombus is there on the endocardium, so that will produce acute mesenteric ischemia, and then late presentation of peritonitis or obstruction. So these are the four causes for acute abdomen with shock. And of course, the ectopic rupture also will produce same picture as the shock. Acute gynecological problems, salpingitis. Salpingitis is the most common cause. Ectopic pregnancy, ovarian cyst, fibroid, ruptured ovarian follicle, which is called the Mittelsmers or mid-menstrual cycle pain. Acute abdomen in tropical countries, malaria. Malaria may produce acute abdomen, amoebiasis, then schistosomiasis, typhoid, abdominal tuberculosis, abdominal crisis of sickle cell disease. Amoebiasis nowadays less often seen because of the fact that every person is taking metronidazole. Severe intestinal hemorrhage can produce. Perforation it will produce, leading on to amoebic peritonitis, and also the right upper quadrant it will produce amoebic liver abscess, which is again a surgical problem. The most important clinical finding for amoebic liver abscess is intercostal tenderness. So whenever you get a suspected liver abscess, look for intercostal tenderness. Typhoid, you get longitudinal ulcers on the anti-mesenteric border, situated within 45 centimeters of the ileocecal valve. It can produce frank perforation and also sometimes severe bleeding. So these are the problems, the surgical emergencies associated with. We call enteric perforation for such ulcers. Then abdominal tuberculosis, reactivation of primary latent peritoneal focus, and acute tuberculous peritonitis can occur. Perforation of intestinal lesion can occur, and rupture of the tuberculous mesenteric lymph nodes are also seen. The abdominal crisis of sickle cell, we don't have in this region, but in the Wayanad area, you've got sickle cell disease. The cells are elongated, sickle-shaped, rigid cells. They block the microcirculation. So these are all non-surgical causes for acute abdomen. And we have got the different types of crisis. Most important is the vaso-occlusive crisis. Then hemolytic crisis can occur. Sequestration crisis when the RBCs are sequestrated in the spleen, and aplastic crisis when the hemoglobin, the cells are finished, there will be aplastic crisis. And then mesenteric adenitis is due to Yersinia pseudotuberculosis that can mimic acute appendicitis. And infection with the cryptosporidium and campylobacter also can produce mesenteric adenitis. What you don't have to operate, need observation and maybe antibiotics. Diabetic ketoacidosis, 10% of patients with diabetic ketoacidosis complain of acute abdominal pain. In children, this may be mistaken for appendicitis. The pain is due to intracellular hypokalemia. That is the reason for the pain. And then herpes zoster, pre-eruption stage of herpes zoster produces severe burning pain in the appropriate nerve root distribution. It will be along the direction of the nerve, especially the intercostal nerves, and spinal disorders can also produce pain abdomen, vertebral collapses of osteoporosis, metastasis, all acute disc collapse can cause, again, acute abdominal pain. Porphyria. Porphyria is a very rare cause, of course, congenital abnormality of hemoglobin metabolism. There will be abdominal pain and vomiting. Porphyrins will be seen in the urine. Photosensitivity is a syndrome of photosensitivity, anemia, hypersplenism, and constipation. This is precipitated by alcohol, steroids, estrogens, sulfonamides, and barbiturates. Previously, the barbiturate era, the condition used to be precipitated by porphyria. And if the urine is exposed to sunlight, it will turn to port wine color. So that is how you make clinically a diagnosis of porphyria. Paralytic ileus, which is nothing but a reflex inhibition of intestinal motility following abdominal operations. Maybe sometimes pneumonia can produce paralytic ileus, fracture spine, retroperitoneal hemorrhage, and metabolic hypokalemia, hyponatremia, uremia, etc. also can cause paralytic ileus without any surgery. And Munchausen syndrome, I think we used to tell that it's functional in the casualty, or the patient will, there are three types of patients. One is abdominal pain groups, the bleeders, then fits, faints, pulses. The fits, faints, pulses will go to the physician. The abdominal pain and bleeders, they will mimic any condition, and they will be really cheating you. And before declaring that this is there is no organic problem, one should be very careful. They will threaten you that they will sue the doctor, all those things, and they will insert any foreign body into any orifice, and then you will be in trouble. You don't know. So always to rule out, take x-rays, everything before say that it is Munchausen syndrome or it is functional. And then decision to operate, there should be definite signs of peritonitis, tenderness, guarding, rebound, definitely may need surgery. Severe or increasing localized tenderness, then abdominal pain and signs of sepsis that cannot be explained by any other finding, then one should. And acute intestinal ischemia. Acute intestinal ischemia, early stages, there will be minimal signs. And then, of course, pneumoperitoneum means one should operate. So the final, I think again, Zachary-Cope, I will quote, acute abdomen is not a disease, but a bad omen. Sometimes you hit the bullseye, but often it is too late when death stands between you and the patient. You must be brave and examine the case from head to foot, but it is very sad you are not found in the ward. More mischief is done because you don't look and try to remember what is written in the book. Or you may think yourself to be very clever and make a spot diagnosis of severe pain, no motion, and a small fever. This you can only do when you are a surgeon, great. But by then you had your chastening lessons, which you don't forget. So that is the rhyme by Zachary-Cope, acute abdomen in rhyme. So thank you very much, and I am free to, will be very happy to answer any queries from your side. Thank you, Prashant, and the listeners. Thank you very much.
Thank you very much, sir. Now, as Dayananda Babu sir has rightly said, it is the time for your questions. Kindly, come forward and ask questions because, see, until and unless we ask questions, there won't be enough room for discussion. And this is a learning time, and you are free to ask questions. Kindly come forward.
I will stop the sharing.
Sir, fine. Sir, there is a chat box question.
Yeah.
Nowadays it is I'm sorry, directly going to that question. The question is that nowadays that sewing is the, defensive medicine is
Yeah.
the, matter discussed everywhere. Is it mandatory that we must do an ultrasound scan of the abdomen in every case of acute abdomen?
I think if you think that there is something better to do an ultrasound, no harm done by an ultrasound. It is very cheap. So if because before you declare that the abdomen is normal and the patient, if you at least you do ultrasound, then you can say that I have done an ultrasound. So better, as I said earlier, it is an extension of clinical examination. So safer to do an ultrasound and also, if possible, a plain X-ray.
Sir, there is another side part of that question. Is there any situation in which, in a case of acute abdomen, the CT, especially contrast CT, is contraindicated?
The contra-CT is contraindicated when there is creatinine of more than 1.4. So if there is before sending any patient for CT, especially contra-CT, one should look for a creatinine. If the creatinine is more than, they will definitely check. And if it is more than 1.4, you can hydrate. It is not absolute contraindication. Hydrate and check. If the creatinine is becoming normal, then you can do. The creatinine is elevated, you cannot do.
Sir, there is another question. In a general practitioner setting, in a patient with acute abdomen, presenting with acute abdomen, should we keep the patient, nil orally till a definitive diagnosis is made?
Oh, this is a really tough question because there are we used to keep all patients nil orally for all acute abdominal cases. But I worked in Saudi Arabia for 5 years. They don't like nil oral treatment. So one Syrian surgeon was with me. He used to say that give food if there is any problem, it will get aggravated, and then you know the situation. So I will go via media. Maybe you can give liquid diets. So no harm. If you suspect something, you can give. No need to give nil orally. The previous old surgeons always used to do nil orally for 2-3 days, which is not a good practice. So what you can do is give liquid diet. Nothing will happen.
Or even water, plain water is fine.
Plain water, because especially youngsters, they will ask for food. So you give some liquid diet, they'll be happy.
Okay. Giving cyclopam, clotavarin, etc. before diagnosis. What is your take?
No, patient needs some analgesia. The rotavirine, whatever cyclopam is antispasmodic, no harm done by. If there is no contraindication medically, you can give.
Sir, just to add a line, because I have seen many situations where in casualty emergency rooms, people give injection metoclopramide and injection buscopan simultaneously, which gives us a push-pull effect. One thing which, slows down, the other, make it movement, and which could be avoided. Have you come across such things?
I think we get all sorts of patients to the especially medical college setup. Not much of problem by cyclopam or buscopan. I think not much problem.
Combining, buscopan and metoclopramide together, which is best avoided.
I think all these things are symptomatic
Yeah,
treatment.
yes.
Metoclopramide maybe to prevent vomiting. Actually, if the vomiting is due to obstruction, you cannot prevent by giving metoclopramide. So
Then, sir, in another trick not a tricky question. There are a lot of questions coming to my chat box, personal chat box, because it's fine. You can send questions to my chat box if you are hesitant to share it in a crowd. Another question is, in a patient with acute abdomen, an adult, if an IV fluid is need to be given, what is your favorite choice?
I think if I will give ringer lactate or saline.
So then, sir, then another question. There are many elderly patients coming to the emergency room or general practitioners for urine retention, an associated complaint or main complaint. Sometimes urine retention is an associate complaint, saying that for the last 2 to 3 hours he has not passed the urine. To what, is there any criteria or is there any guidance rather than guideline in dealing with such situation? Because especially differentiating, the diagnosis.
No, retention, of course, you have to relieve the retention. There are 2 types of retention, acute retention and chronic retention. The difference is acute retention is a painful retention. So if it is a painful retention, you have to immediately relieve. Chronic retention is a painless retention. So whatever is the cause for retention, you have to relieve and then examine. Actually, before clinical examination of the abdomen, it is always safer to put catheter and leave the distension.
Yes. Sir, then there is a very classic question, in my chat box. Sir, will the examination of an acute abdomen finish without doing a rectal examination? And there is another part 2 of that question. If, documentation, everything is very important, particularly when, referring a patient. Without doing a rectal examination, can the patient be, referred?
I think no harm in doing a rectal examination because that the initial doctor himself can do. And if you get some observations, say for example a blood per the finger stall, then you may suspect a GI bleed. So that you can do. No need to hurry the patient. If a patient is having hypotension, of course you don't. Otherwise, no need to hurry.
Sir, that was the next question, maybe the last question in my chat box. That is actually when to refer. That there is a subset when to refer. The patient, the severity of the pain or the vitals, which should be given priority.
So initially I said that signs of peritonitis, definitely you should. Gas under the diaphragm, definitely you should send. And if rigidity or rebound tenderness is there, one should definitely refer the patients. So, and then of course tachycardia. Tachycardia is very important. A tense, tender abdomen, with tachycardia, never keep in your hospital if there is no surgeon. So without surgeon, never keep tense, tender, rigid abdomen with tachycardia. And of course, hypotension is 100% you should refer.
Sir, there is a very practical question I must not ignore. The question is that the doctor working in periphery, there are, the medical college far 25 kilometers, he has written like this, medical college far 25 kilometers away, and there are private hospitals. The patient is, may not be affordable. Still, should they, motivate the patient to go to a nearby hospital? At what condition? Particularly that when the tachycardia was discussed.
Once again, whether you should refer or not. What is
No. The question is timing.
Yes.
Timing available, time frame available while referring such cases. Like, they can wait for a long travel for a 30-kilometer away medical college.
No, the 30-kilometer away is not a long travel, I think. I will say 1 hour.
1 hour.
1 hour. So 1 hour, no problem. So you can refer. Only thing is, you should never refer a patient who is going to die. So dying patient, if you refer, better convey the message that a patient is dying and keep it there, unless until they say that we want to take the patient away. So if you force and on the way patient will die. So a dying patient better keep and give the message that he is dying, we cannot do anything. Or of course, if you can save the patient, of course, then you should send.
Very practical answer, sir. Thank you very much. There is another last comment or type of a question. What is the rough cost of a patient? Patient must pay for acute abdomen, ECG, ultrasound, CBC, urine, and all. It depends on the institution where the right, sir. So,
Yeah.
you know.
It all depends on the institution where you practice. If it is a small hospital, everything will be cheap. If you go to a high-tech five-star hospital, everything will be costly.
And that is why we are empowering general practitioners, right?
Yeah,
Sir?
definitely.
And
Right.
friends, we have a great faculty, eminent faculty, none other than Professor Emeritus Dr. Dayananda Babu sir. Listening to him alone is a blessing because great teachers, the wisdom of great teachers getting shared is a something which you can never forget. I still remember your favorite student, sir, Dr. Manju. That now she's a renowned laparoscopic surgeon in Kochi Medical College, and there are umpteen number of I just got reminded of Manju, and similarly there are umpteen number of great surgeons who has taught by Professor Dr. Dayananda Babu sir, and we are really blessed with your presence, sir. Thanks a lot for your interaction, your presentation, and your presence and your blessings for the crowd. Thank you very much, sir.
Welcome, Prashant, for all those nice words. Thank you very much. Thank you.
Thank you, sir. Dear friends, Indian Medical Association, the College of General Practitioners, coming out with the weekly webinar series will be live again at 8 p.m. sharp on next Thursday with common dermatological problems and correct solutions. It's very important. And you are going to listen to the renowned dermatologist, Dr. Radhamaniyam, a very classical person, a very excellent teacher par excellence. And let me tell you, don't miss it. And this month, or the next coming months, till November, you are going to get a great feast of academic, extravaganza from eminent set of faculties. And so don't miss it. And don't be selfish. Share it, because let's empower each other. See you next week, Thursday, 8 p.m., empowering everyone in modern medicine. Thank you very much and good night.
Thank you very much, Prashant.
Thank you.
And all the eminent general practitioners.
Thank you.